Hello? Hello?
Hello.
Hello? Hello? Hello?
Yes, hello.
Yes, hello, Dr. Diri, how are you?
Thank you. How are you?
Hi, good morning, everyone.
Good morning to you all. I hope you are doing well.
Yes, we
So,
are.
Chief
Can
Lennox,
you
you are
hear
not
me?
there. I think you may. Yes, I can hear you. I think you can now take over. You have to set the ball rolling here. I see some people are still to join. Huh?
Okay.
Uh-huh.
So I can see Dr. Sabiriri. Hello, Dr. Miriri, how are you?
Good, thank you. How are you?
Yes, and Marco Shoko. Do we have Dr. Charasika here? Yes, I can see something. Hi, Doc. Charasika.
Good morning, how are you?
I'm good. You hear me? Clear?
Loud and clear.
Nice. We are also waiting. We are actually waiting for Dr. Mahomba to join us. She confirmed that she will be with us. More minutes so that she can join us, and then we can. Yeah, they spoke about it. So, yeah. You know, hello, Dr. Mahomba, how are you?
Good morning and hello.
Oh, we are so thrilled that you are part of us. Thank you very much for joining us. We were about to start.
It's a pleasure.
Yes.
It's a pleasure.
It's not every day that it's not in Shona they say it's not headquarters.
You are the headquarters.
Thank you very much. So I think we will get the ball rolling. Okay. Yeah, you can say that again. It seems that there's someone who's got some background noise. I'm not sure where it's coming from. Yeah. Okay, welcome everyone to this webinar, which is very critical at this time. The Media Center, I would like to invite you all to this particular webinar on the topic COVID-19 vaccine, dawn of post-COVID-19 era or the beginning of new programs or new problems, sorry. My name is Lennox Mhlanga. I'll be your facilitator and hopefully we'll have more people joining in as we proceed. We are happy to have such an esteemed panel, and we'll also like to announce that this webinar is also being on Facebook. So we have a much wider audience that is watching us or following us on Facebook. We will start perhaps by looking at how we this webinar. We start with our key speakers, and we've got 4 panelists, and we'll be introducing them. And then we will have what we call a plenary or a session where we will allow the questions that are coming from various platforms to be tackled. This is also a very important aspect in that we need to have a conversation over this important topic of COVID-19. We are being hosted by the Media Center, and we are represented here by Ernest Mzengi. I noticed that his mic is muted because we would like him to give us a few remarks before we proceed. Tino, you're over there. Ernest Mzengi, can you please open the session for us and give us context? The mic is yours.
Okay, thank you, Lennox. Basically, this is a discussion on the COVID-19 vaccine, and we, as media center, we are people who facilitate access to information. We also facilitate freedom of expression. So we are doing this as a way of making sure that people have access to information. As you can see, our audience here is our panel represents a cross section of actors. We have healthy experts here, we have media people, the audience represented. So it's about facilitating access to information about the vaccine and also raising certain issues that people may have in mind pertaining to the vaccine. And also, we want to look at a situation where some have opted not to be vaccinated. What are their choices? They're not going to be exposed to segregation and so on and so forth. So basically, this is about information. This is about people's concerns being addressed. I'm happy that we have Dr. Maomva here from government. I'm also happy that we have Dr. Jirishaka, who is also here, and Dr. Mbiriri, who will help us from the point of view of lifestyle issues and so on and so forth. So this, I think I hand it back to Lennox.
Thank you, Ernest. We won't waste anyone's time. We will proceed to our first presentation, which will be made by Dr. Agnes Maomva. Dr. Agnes Maomva is the Chief Coordinator, National Response COVID-19 Pandemic in the Office of the President and Cabinet. And we are honored to have you on this platform. Dr. Maomva, we basically have budgeted 2 hours for this presentation. So we will give you initially 15 minutes, and I'm quite sure that there will be more time for you to expand. I know 15 minutes is a tall order, but I'm sure with what you have experienced in, being someone who's been at that high office, 15 minutes is a walk in a park. So over to you, Dr. Agnes Maomva. Oh, it is muted. Okay.
My apologies.
Oh,
I was muted.
okay. All right.
I thought I should have asked you earlier how long I had so that I would prepare appropriately. But I chose not to ask you because I thought I just still need to give you some things that I want to give you in addition to what you want to hear. I think many times you have questions because we have focused on a specific area that you want to hear and forget about the other areas. So I hope I can share my slides. There are many of them, but some are really to make sure that when we do go into the question answer session, I can bring them back up and we are able to see the data or the issues that I will be actually speaking to. So let me see if I can. I hope you can allow me to share my screen. Host disabled participant screen sharing. Oh wow, okay. That is not going to happen. So that's to your disadvantage. Can that happen? Hello?
Your screen, I think.
It says of the screen sharing.
Okay, I think Tino will work on that.
Yeah, I can continue, but I think it's usually really important for you to see some of these things. It looks like you wanted me to behave like a politician, talk from a speech.
No, actually,
and not be very.
our host was informed that some of our presentations will actually be, we will have to be screened. So I'm sure he is working on that. Mahomva's screen.
Allow me to
Yes,
share.
there we are.
No. Allow me to share. Host disabled. What does that mean? Host disabled participant screen sharing. I still get that.
Okay, I think he's working on something.
I'm seeing his screen, I think.
It's his screen, yes. He should actually be enabling you instead. Just give us
Thank you.
Allah, yeah, I'm informed that Dr. Mahomva, now you are in a position to share the screen. You may want to try to share.
You can tell me if you see it.
Yes, we can see it.
Perfect. Thank you much. I'll run through it because I do know it's really the discussions that really make good sense. But without this quick background, we might find ourselves, answering appropriately. So I chose to really, first of all, give you the COVID-19 pandemic situation, a quick overview, and topical, and everybody so very much. As I said, that brief overview, just looking at the number capacities built, I think that context is so critical. Many of the questions that are coming regionally, globally, you name it. And quite clearly, we have not been spared. A smaller country as we are, our numbers by the end of yesterday, 6,289 cumulative recovery, 33, and very concerned about the deaths, 1,487. Looks like a small number when you compare to other numbers elsewhere, but we're very concerned with the case fatality rate that remains at 4.1. That's quite high, among the highest in the region and indeed elsewhere. So we're not happy with that one, but we're looking at it to see what's happening. I want to remind you that when we started, the media were asking us, is Zimbabwe thumb sucking? What is guiding us? We don't have a plan. We don't have a plan. We had a plan. We specifically put in place a national preparedness and response plan right at the very beginning, before we even had the first case. And the goal of our plan is adverse COVID-19 impact includes health, economy, you name it, but we were specifically strategic and say we want to focus on the morbidity and mortality. If those numbers are up, people are dying, there's economy to talk about. It included the prevention, containment, and mitigation strategies that we have continued to sing about, and it was very much science-based, guided by the 8 strategies that WHO has also as contact tracing, surveillance, testing. And I remember way back then you were saying we're not testing enough. We had clear strategies for that. Case management, if you did get it, what is it that was going to happen to you? Are you managed in hospital? Are you managed at home? Infection prevention control, the risk communication, we're here to introduced 7 confirmed laboratories, including private ones. We actually further expanded that from the national to the district. Every single district, 52 of them, and now as we're speaking, they all do testing for COVID-19. Case management, I mentioned it earlier. We had our ministers going around, teams on the ground, Minister of making sure there were facilities for isolation. Initially, it was just the cases, and I remember you, the media, holding us accountable. Why is it just central? We went on to put additional isolation facilities in every single province and district, if you like. So we once again really, and also in line with government ability over the health of its citizens and its strategy and the thrust toward the self-efficiency, importing substitution rather, the national response actually also builds capacity for local production of COVID-19 commodities. You are aware the local universities set up units producing PPE, sanitizers. Local pharmaceutical companies stepped up in terms of production of those medicines that we use to manage the COVID-19, whether it's the paracetamols for your temperatures, the antibiotics, you name it. And of course, the small to medium scale enterprises receive support to produce reusable face masks and so on. So once again, not just the whole of government, but also capacity building our own. So when we do all that, the first wave, as you can see, was now compared with the second wave. In fact, we managed it very well. Numbers went down, and everybody started thinking right there, well, this is just a cold flu. There's nothing to worry about. After all, we're now getting into summer. Really nothing will happen to us. And so when we were pushing the messaging, and thanks to your help as well, pushing the message, please remain focused, please stay away from crowds and so on, nobody was listening. Nobody was listening. The complacency was just unbelievable. We're seeing our numbers going up. You, the media, have asked me several times, did you expect this? Were you aware of? We expected it. Based on our behavior here, we just knew, we are trouble, and the trouble got us, and the numbers started shooting up. And when we saw them shooting up around festive season, as we're going into the new year, we realized, whoops, let's really tighten up, put in another lockdown. Exactly what happened. The president announced that, and of course, we worked flat out, surge specific strategies, activities. We ran around with them. But in addition to that, we continued pushing that first prevention front that I talked about from our original plan, the 8 pillars of surveillance, you name it, social measures in terms of making sure that you continue with your mask and so on and so on. That's what we're calling the first prevention front. And it remains the rock to our response and we just need to hold that. But in addition to that, this is where we realize let's really run with it. While we want to use vaccines, it was in our original strategic plan, preparedness and response plan. We realized we needed to actually move faster than what we were thinking initially. And hence you saw us introducing the second prevention front, that is the vaccine deployment. And that's what you really want to hear today. But I just wanted to give you that background to make sure we're on the same page. So the government went on to say, okay, through cabinet, as you saw the structure that I showed you, in the meeting of the 9th of February, the intention for introducing the vaccine is to reach 60%, at least 60% of the population. And of course, the choice of vaccine, according to that statement, then was to really be based on science, with adequate research and findings guiding the decision making of that. And of course, to prioritize healthcare workers. We're very aware in our numbers, we had seen so many healthcare workers contracting the disease, and it really compromised how we were going to then help everybody else. So that was really critical. The vaccine, of course, was to be sourced from multiple manufacturers. Everybody has cried out, why Sinopharm? Why don't you get this other vaccine? Cabinet was very, very clear. We are sourcing from multiple manufacturers, but it has got to be based on science. So the broad objective of our COVID-19 plan is to ensure high quality vaccination services, reduce morbidity and mortality. Look how it's linking to our very original a goal of our preparedness and response plan. We said we want to really to counter the adverse effects of COVID-19, but we focus on morbidity and mortality. And this is what this vaccine is actually contributing to. The National Deployment and Vaccination Rollout Plan provides a framework for deployment, implementation, monitoring of COVID-19 vaccines, and ensuring, I want to emphasize, ensuring that plan and the related financing are well aligned to the Zimbabwe COVID-19 preparedness and response plan, as I've mentioned, that implementation is fully integrated. And when talk just in structure already, and us is expanded program on immunization. Everybody knows, as we're speaking now, there are nurses out there vaccinating on measles, on polio, and so on. Those structures are robust. WHO has continuously singled out Zimbabwe for a very, very good immunization program. There's no need for us to reinvent the wheel. We got a bit concerned, surprised when some were being quoted in media saying, oh, experts have told us that healthcare workers haven't even been trained. So how are they going to roll the vaccine out? And we're saying that expert perhaps is not an expert, because quite clearly they don't seem to appreciate or know that we already have immunization teams well trained on the ground doing vaccinations as we were preparing for this edition vaccine. So people were already trained. What was simply left is vaccine, which does not take a long time at all. So this is where we were. And of course, vaccination strategic plan, once again being very strategic, we looked at specific areas, pillars or strategic areas that needed to be covered. And there are 12 key strategic areas that we're looking at with our vaccination. And this slide here is showing you that context has got to be there. We were very clear, we're not reinventing the wheel. We've got to use systems that are in place. We need to know our numbers. We need to know who is more vulnerable in order for us to really move forward with this rollout. Regulatory preparedness, I will give a little detail on one. Planning coordination of the vaccine introduction, I've already said it. No need to reinvent the wheel. We must use systems that are there. They just need to be strengthened. And we move on with resources and funding. I'll touch on that a little bit in detail because everybody's asking questions about that. The target populations and actual vaccination approaches or the delivery itself, I'll touch on that a little bit. And of course, supply chain management. I don't want to bore you with the details of that. It's really cold chain systems, you name it, already in place, just us riding on them, strengthening them. Human resource management, including the training, I've just that seriously. We paid attention to that because there is no way we would want to introduce a vaccine that has got so many side effects to the point where it's not useful for you and so on. And of course, the general monitoring system, I won't dwell on that because, as I said, we have a robust Zimbabwe expanded program in immunization working well. Ride on that one. Surveillance, 19 vaccination surveillance is again riding on what we do with other vaccinations, but ensuring that any peculiarities to the COVID-19 vaccine are included. And of course, finally, we took it upon ourselves to say our deployment rollout plan has got to say at the end of it all, when it's said and done, have we evaluated the whole process? Because next year, the year following, we might actually have another pandemic, and we need to learn lessons and say, we have evaluated, these are the issues that came out. As we move forward, we are ready and prepared for anything else that might come our way. So this is really the summary of our deployment, the vaccine deployment and rollout plan. So if I may give a little bit of detail in areas that I have really been continuously asked about, questions keep coming up. The COVID-19 vaccines to be registered by the Medicines Control Authority of Zimbabwe. In my updates, I have said it several times. In my past 2-3 updates have really just been on COVID-19 vaccination and so on. And this is really under the emergency use authorization. We say emergency use authorization because there is no COVID-19 vaccine that was there before this disease came on. So you will not have a vaccine that is always waiting there and people get concerned. Are we using it in emergency? Are we experimenting? No. We are looking at the science that has just come out, and because this is an emergency, we have to move as fast as we can to protect our population, to protect you and I. And that's exactly what is happening globally. It's not just about Zimbabwe. The secret is using our science. And science is not about global science. It's about global science, yes, plus local science. That local context. What are our numbers telling us? What is it that we need to do to adjust? Not to just say if the world says you must vaccinate over 80% for herd immunity, then you say, yes, let's also do the same in Zimbabwe. Have you also looked at your data? Have we looked at our data to then say, what percentage do we need to do, and not just to take carte blanche what is coming from elsewhere. And of course, the Ministry of Health and Childcare has set up and is implementing a safety monitoring plan to enable swift detection of those adverse events if and when they do occur. So if I move on to resource funding, which is another area, people say, oh, you have just received COVID-19 Sinopharm from China. Are we going to be able to vaccinate the percentage you're talking about? Why are we just depending on donors? Not at all, not at all. We're very strategic. This is part of that strategic area in our rollout plan. Treasury has set aside $100 million dollars for procurement of the vaccines, $7 million for the actual operational costs that we're incurring. And of course, the many well-wishers, including the private sector. The private sector, I remember we met with them at State House with His Excellency, Treasury, outlining what we were expecting, what we really need to move on, making sure that we're roping them in, but at the same time making sure that that coordination is very clear. Other nations, as I have just pointed out, China, and so on and so on. We are very strategic. We're not narrow-minded. And so this is the summary of that, the resource mobilization, what we are actually using. Once again, to emphasize, it is the government of Zimbabwe that is leading this process. It is not about a donation. We have procured 600,000 doses of Sinopharm vaccine. And by the way, Sinopharm vaccine, it did go through the regulatory processes. We demanded, we requested, we got all the paperwork from the clinical trials, phase 1, phase 2, you name it, from the manufacturer. Our Medicines Control Authority went through it, and they then issued the emergency use authorization with the evidence and so on. And of course, China has donated 200,000. That's what we use now. They went on to donate another 200,000 of the same vaccine, Sinopharm. Other countries that have come on board, you heard last week with the VP, who is the Minister of Health and Childcare, talking about the India donation of 75,000 doses of Covaxin. Once again, by the time he was announcing it on the 4th, the Medicines Control Authority had already done its work, had requested for all the paperwork. There were a bit of delay here and there, and we were saying we're not moving until we get all the science and the paperwork. And of course, on the 3rd, they cleared it, they got it, they issued that emergency use authorization with the evidence, with the science, and of course the VP went on to announce it to you. Russia has also pledged donation of 20,000 doses of Sputnik V vaccine. Again, when the process I'm talking about, the regulatory processes, making sure we are very clear that the science has been followed, that this is a safe vaccine for us, goes through. UK at the very beginning also offered to give us some donations, but I think theirs is very much linked to the WHO Gavi COVAX facility donation. And on that one, we finally, everybody was very concerned.
Hello? Hello. Go on.
Hello, we seem to have lost Dr.
Yes, we have
Dr.
lost
Mahomba.
the-
Yes.
Yeah.
We will try to get her back.
Oh yes, I think yeah, we have lost. Maybe we may get to other steps.
It seems that we have lost our keynote speaker. I think what we'll do to manage this, whilst we get her back on board, she'll rejoin us later. We will ask Dr. Charasika to come on board. Dr. Charasika, can you be ready to take over so that we manage this mini crisis that we are having, where we have lost our keynote speaker, Dr. Charasika?
Yes, thank you very much.
Oh, she's.
Oh, is she back?
Hello.
Hello.
Yeah,
she's back.
Dr. Mahomba.
Yes,
Yeah.
looks like she's back.
Yeah.
Okay. We had lost you there, Doctor.
Got cut off.
Yes.
I got cut off now. I'm wondering whether it's running on without you hearing me. I'm not sure where we were now. Let me see if I can share my screen again. Very interesting. Is that where I was now? I don't even remember.
Yes. Okay. I hope at some point you are not speaking to yourself.
I don't know. You're going to tell me where I was. Then I can continue. I was talking on resources and funding.
Yes.
Were you still hearing me there?
Yes, we were. Yeah. Slide.
I went on to the next slide. Were
Yes.
you still with me on this one? Okay, where I was now, WHO Gavi COVAX facility, we have 1.2 million worth of doses. We have also signed with the Africa Union facility. And as I mentioned, we have the private sector really contributing. I know there were discussions, negotiations with the Treasury, who are really leading in this resource mobilization for vaccination, talking even with the medical aids and so on. How can they come on board? What is it that they need to do to make sure that those who get it for free? So if we move on to the target groups for vaccinations, which is another area that people have asked a lot of questions about, we are basically talking of 3 phases. Phase 1 is the population at the highest risk, and it's in 2 stages. Stage 1, the frontline workers, and then stage 2, which are those with chronic illnesses, elderly, you name it. And then phase 2, lecturers, all school staff population, and so on. And finally, anyone and everybody else is there. So this is basically one thing with clarity, that the population 16 children is 41.2%. Quite clearly, if you subtract that from the total population, our numbers, the percentages that we have to cover suddenly are different from what you're seeing, what they are saying in Europe, in America, because our demography is very different. We have a younger population, more children, and we're not targeting those underage for this vaccination. And so hence our population, our vaccination percentage comes around the 60% we're talking about. Very much guided by global science, by science on the ground. And so if we now look at the actual rollout, delivery, other things in Zimbabwe, how are you going to be able to move the vaccines to all the provinces? We did it with a bang in almost a day or 2, because we already have structures in place. The community that I've talked about earlier have these trucks that are doing this work every single day. It is not new. Hello? Not again.
You are still audible.
Okay. I thought I was cut off again. Okay, all right, let me finish. And so the rollout was on the 18th. You were all there. VP actually static facilities. The outreach teams have sort of been withheld a bit, but we again are discussing that to see, with our numbers that are slightly a bit on the low side, how can we vamp up and make sure that we do vaccinate the percentages we want, to make sure that we are ready and prepared for any potential third wave, as I pointed out earlier on. So the other area that people really always want to know about, that is also creating a bit of fear, hesitancy, vaccine safety monitoring, managing of those adverse events following immunization, and the injection safety. Of course, in partnership with the unit that I've just talked about in the Ministry of Health and Childcare, there's the national, what we call the National Pharmacovigilance and Clinical Trials Committee, Medicines Control Authority of Zimbabwe, MCAS. These are the main drivers of the vaccine safety and surveillance. This is why MCAS, Medicines Control Authority of Zimbabwe, at the forefront. Before we even import the vaccine, they will have checked the science, the paperwork, and so on, to make sure that once we start vaccinating, we're not worried about the vaccine, we're not safe. We're now looking at what other issues, side effects, the usual side effects that might come up, and how we can manage them. So COVID-19 vaccine safety surveillance is being guided by already existing ministries' adverse event structures, following the immunization surveillance guidelines that we have always had, and the WHO COVID-19 vaccine safety surveillance manual. WHO came up with that, and we've read it from page to page several times, making sure that that global guidance science is speaking well our local science, and we're able with confidence. So this is a bit of detail on that vaccine safety monitoring, management of adverse events following immunization. That's the AEFI in injection safety. Will be affected. We are already doing that training. Remember, I said our team is already trained for vaccination because they're already doing vaccinations. However, there are specific, unique things to COVID-19 vaccines. These are new. So we've done all the trainings in terms of training of the committee itself, training, preparation for the healthcare workers, for them to be able to identify and manage cases, whether it's those severe, which can come, the anaphylactic shocks that we talk about. Remember, any vaccine, even paracetamol, one can react. and hence you can actually, that is no reason for one to stop from getting the vaccine, for everybody else to stop rather. We are aware you can, if some people don't take peanuts, they eat peanuts, they can even convulse and go on to die. That's a reaction. So it's really being trained to make sure that they appreciate that even more where at the end of the first wave. However, there's need to remain vigilant. Avoid, remember that complacency arrow that I put between the first wave and the second wave. If we do what we did at the end of the first wave, there is no two ways about it. We will find ourselves in a third and potentially even bigger a wave, because this vaccine, this virus is very clever. It mutates. It says, you got me in the first wave, not to worry, I've changed, I will attack you in a different way, and we will not be ready. That's exactly what happened with the second wave. We not only became complacent, but we actually also got hit by the South African variant. When our scientists then did the genotyping and so on in February, they actually found that we had about 61% and beyond. And in fact, in December, towards the end of December, January, it was actually about 90% of the variant was the South African type. And it explains how it spread so quickly, transmissibility was so high, and so on. So we are saying once again, please, let's not be complacent and think, nothing can, surely we can't get anything bigger than what we already have. It can happen if we're complacent, if we don't pay attention. We must continue with the 2 prevention front measures that I talked about, just summarizing it. The public health and social measures, public health, PHSM, which includes surveillance, doing surveillance, testing, making sure cases are managed appropriately, paying attention to our ports of entry. And yes, the social measures for you and I in the public, the social distancing, avoiding, yes, relaxed a little bit, lockdown, but you still really should not be going into those gatherings if you can avoid it. If you can, it doesn't mean because we have relaxed, oh yes, let's go partying, let's have the Ginimbi style funerals. No, we really must pay attention. Finally, the vaccine you really wanted to talk about here, which is our second prevention front, we have got to pay attention. Let's get vaccinated. We saw a number starting slow. They're picking up, hitches here and there. That is the nature of any new program. We will never expect it to be 100%, but we're making such fantastic progress. A lot of people from the region have actually called me asking me, how have you managed Zimbabwe? Initially, we thought you were way behind in terms of vaccination, because there was so much misinformation about Zimbabwe is not wanting to bring the vaccines. Zimbabwe doesn't have a plan. How can we even talk about it? The fact that you don't have information on a certain issue does not mean the information is not there. Inform each other, help each other spread the correct information to give confidence to our population. If we continue working together, I have every confidence we have this under control. Thank you.
Wow, thank you very much, Dr. Mahomva. That was a very comprehensive presentation. It shows that you have actually done this quite remarkably so many times, and I'm getting comments here on how articulate this presentation has been. And thank you very much, and I'm quite sure that you will continue to still be hooked on, or so that you follow the rest of the conversation, and perhaps at the end of our webinar, towards the end, you can engage and respond to some of the questions that come through. Just some housekeeping issues. If you're not presenting, please can you mute your mic? And secondly, if you've got any burning questions as the presentations are going through, please do not hesitate to use the chat box at the bottom. We will take note of your questions, and we will direct them to those of the panelists that will be in a position to answer them. At this point in time, we would like to invite Dr. Eva Charasika that's Farai Charasika, to join us. He also has a presentation, and I would like to ask Tino to ensure that he has got the presentation rights for us. Hi, Farai, how are you doing?
I'm good, thank you. How are
just
you?
as a formal introduction, Dr. Farai Charasika is a public health practitioner. He's a clinical mentor and a medical doctor who has worked with public, private, and civil society institutions across the globe. Dr. Farai Charasika, the floor is yours.
All right, no, thank you very much. Please confirm you can see my screen.
Yes, we can. Thank you. You can proceed.
Thank you. So thank you for the opportunity to be able to have a conversation with you all. And also thanks to Dr. Mahomba for a good and comprehensive and how strategic we have been. So thank you, Dr. Mahomba, for that presentation. So I'm going to do a bit of a deep dive around the vaccines. I think Dr. Mahomba gave us the context of where we're coming from and our plans as a country and done for vaccines and then putting some genetic material from the, and then there are vaccines from proteins that surround the virus. So in terms of COVID, there are some proteins that surround the genetic material. We take some of those proteins and then introduce them to the body. So we'll talk a little bit about each of those types of vaccines and how they work, and key considerations for us here in Zimbabwe. But basically, those are the four categories. And just to kind of let you know that globally, across the globe, there are at least 48 vaccines which are either on the pathway to being approved, or some have been approved, whether it's by WHO or the FDA or the various regional bodies that accredit and validate vaccines. So there's about 48 in the pipeline, but all at different stages. Some have finished clinical trials and fully approved, and those are the names that you commonly hear, and we'll look at those. And then there are others which are still down the road coming. So big number of options in terms of vaccines and which ones make the most sense. And each country must decide what makes sense for it from a cost perspective and logistics perspective, and in terms of the science that they are looking at. And they all have different costs, and we'll look at all these various vaccines. So just remember this slide, and we'll come back to some of this information in detail. So again, just so we can have some information, so I think the big names that we first heard were Pfizer, the Pfizer vaccine, which is the very first column. I think that's the one that we heard that came out first, and everyone was excited about there's now a vaccine. And a little bit quieter was the Moderna, which came alongside with that. And the other big name which we're hearing was the AstraZeneca, Oxford, and that came out as well. And then we also had the Gamaleya vaccines, and of course I've included here Sinopharm because that's what we are at present using through the different mechanisms, the COVAX and the African Union. We will probably get a few options. We also know that the Indian option will be coming through into Zimbabwe. But these are the various vaccines, at least, that are in play, with Sinopharm also being the one that we have started with here in Zimbabwe. So they have different efficacy rates, and efficacy rates basically means how effective it is in preventing a serious case of COVID. So if we look at Sinopharm, which we'll focus on a little bit, 86% effective. So that's Very good. There are trials. Every time you do a new vaccine or a new drug, you go through trials, phase 1, phase 2, phase 3, where you're looking to learn different things at each phase. And basically, once you have completed phase 3 trials and you've got collected all the data in terms of what's working and what's not working, in terms of side effects, you can then go for approval. So phase 3 is a critical stage for a vaccine to go through. And yes, the vaccines have been developed quite fast in a space of 12 months, but we're able to go through all the 3 phases and be able to determine the data. And so that's how we get the efficacy, the effectiveness of the vaccine and how important it is. If we go to the section just second from the bottom, where it says cold chain, that's a very, very, very important section for countries to consider. So the Pfizer that came out first, everyone was excited about that, but that Pfizer needed to be transported at minus 70 degrees Celsius. So you need liquid nitrogen and carbon monoxide and frozen carbon dioxide to be able to transport that, which can be quite complicated and difficult for developing countries. Because the supply chain becomes quite complex. So we heard, Dr. Mahom tell us that when the vaccines arrived in Zimbabwe, we were able to deploy them across the country within a couple of days, within 2 or 3 days. And that's because the Sinopharm which we are using has got a simple refrigeration temperature and process, which is similar to all the other vaccines that we already use, our measles, mumps, rubella, our polio, our TB. It can use the same supply chain. If we had gone for Pfizer, it means we had to set up additional supply chain mechanisms, which are quite costly and expensive for us. And similarly with the Moderna, down to minus 20 degrees Celsius, you can then take them out and put them in your fridges and store them for 2 to 8 degrees after you've stored them for a while. But just setting up that system would be quite complicated for us as a country. And, think about some of our rural areas where the power is not yet fully there. The refrigerators, we've got refrigerators, but they can only really do the, 0 to 10 degrees Celsius. They can't go lower than that. And there's no power to power deep freezers. So we really need to think about all that. And so that's one of the key considerations that a country has to think about as they roll out vaccines. So looking at Sinopharm again, and right at the end on the extreme right. So we can store it for between 2 to 8 degrees Celsius for up to 30 days. So that works for us as a country. And any vaccines that we'll probably bring in will probably need to be in that range as well, so that we can get them out to our rural health centers and our health facilities. The trucks that we use as a country, the refrigerators, all are operational in that temperature range. So any vaccines that even when we get other vaccines besides Sinopharm as a country, we'll need to consider that temperature maintenance. What happens is if the temperature goes higher, basically your vaccine is destroyed and becomes ineffective. So we must maintain those temperatures. So very quickly, I'm not going to spend too much time on this because we've talked about this, but basically looking at the different vaccines, it's basically telling you the name of the company, the type. So remember, we talked about there are 4 types of vaccines, and then how many doses you're supposed to get, and the number in brackets is how many days in between. So as of now in Zimbabwe, we're using the Sinopharm, so row number 2. So let's look at that. So it is an inactivated virus. That means it's a virus that's been killed and made inactive. We need 2 doses, and those are done 21 days apart. And it's done through IM. So IM means intramuscular. So it's an injection into your muscle, and that's typically just on your shoulder, the same way you'd get your TB jab. So really that's where the vaccine we are currently using. So as other vaccines come in for use in Zimbabwe, you can look at this chart, and that's what will guide us in terms of what needs to happen and what kind of vaccine it is. So I won't spend time on this. This is a little bit technical, but again, still really telling us the same kind of thing and how the different viruses, where each type of vaccine sits. So a little bit about the types of viruses. I think this is important. Types of vaccines, my apologies, this is important. So inactivated virus, and that's what we'll be using. That's what we're using with the Sinopharm. So we basically get samples of the virus, and what the Chinese labs did is they got different viruses. They used 3 different types, and then basically they killed them with a chemical. So the virus is dead. It cannot replicate, and it can be stored at room temperature, or like we said before, between 2 to 8 degrees. Now, what this does is that once that virus has been killed, it cannot multiply anymore, but it still exhibits and shows the properties of the virus. And the way that vaccines work, all the vaccines that we get, the BCGs, the MMRs, the polios, measles, all those things, the way that they work is that you're introducing just a tiny little amount of the infectious agent, whether it's dead or weakened, so that your body learns and understands how to attack that disease. So your body then generates memory, it generates new cells, it generates an immune response that says when this kind of disease comes into the body, this is how we will react. And so that's how a vaccine works. Basically, you're introducing a piece of protein, a piece of virus, a piece of DNA that looks like the disease, and then your body is then able to learn and understand it, and then develop the cells, or in the olden days you used to say develop masoja. The soldiers in your body learn and know how to attack when this kind of enemy comes in. And then from there on, if you ever get that infection, your body mounts a response immediately, because now it has got memory on how to deal with this infection. So really, that's how vaccinations, immunizations work. So is it inactivated viruses? There is live attenuated or weakened viruses. So these are viruses where it's not completely killed, but it's made much weaker. And it generally only needs 1 dose, and it generates long-lasting immunity. So here, the immunity is a little bit longer than normal because you've got a live virus, and so your body is able to detect that, and so it mounts a robust immune response, almost like it's dealing with a live infection. So that's important. As of now, we don't have any of these vaccines in Zimbabwe. They may come, depending on what we end up procuring as a nation. Then we have what are called viral vector vaccines. And this is a new kind of technology which just emerged. Basically, you're taking the genes or the genetic code from one virus, and you're putting it into a harmless virus. So in the case of COVID, you'd be taking, for example, the COVID genetic material, and you put it into a harmless virus, like, for example, the common flu virus that we have. Everyone has flus. In June, July, we have flus. It's harmless. You have your flu, you sniff, and you get on with life. So you take some of that virus, you put some of the COVID, and so what you're doing is you're introducing and allowing the body to be able to identify what COVID would look like if it was to attack the body. One caveat with this is that it cannot be used in immunosuppressed or immunocompromised people. But this is a new technology that is still being used. And again, as of now, we don't yet have this in Zimbabwe. Then finally, we have the DNA and RNA vaccines. And basically what these are doing is you're getting a bit of the genetic code. And then basically the body then responds very quickly. These are much cheaper and easier to mass produce. They do produce strong reactions. So why do we give 2 doses? I think in one of the earlier slides I showed us where we said we do 2 doses. Why do we do that? What we basically want to do is we wanting to boost the body's ability to respond. So we give the vaccine the first dose, and so your body has what we call the primary immune response, that first rise in the graph. But what tends to happen is after a bit of time, your body maybe doesn't mount enough cells, or it only mounts a few cells, and so that immunity starts to go down. So what you do is you bring in a second dose, and what you do is you're strengthening, you're reminding the body, look, this is how you're going to deal with this. And so again, when you strengthen that, basically you get a secondary immune response. And so what happens is that your resting state, you now have a stronger immune memory. And so that we do with vaccine. So here, that's why we get 2 doses. If you remember your TB or BCG vaccines, you'd get one when you're a baby, you'd get one when you were in grade 1 or creche, and then before we used to get one when you're in grade 7. So you get 3. If you're older and you look on your right shoulder, you will probably see 3 scars on your right shoulder. And that was because what we wanted to do was to keep reminding the body of how to deal with this infection when it comes. So that's what we do when we're doing vaccines. So with COVID, we're doing 2 vaccines for most of the 2 doses for most of the vaccines. And the idea there is to remind the body in a short space of time, this is what the enemy looks like, and this is what you need to deal with. And so you get that higher level of immune memory cells, which is what we're looking to do. So again, this is a little bit clinical, and I think Dr. Mahomba has already spoken about this, so I'm not really going to talk too much about this. This is really talking about the stages of vaccines when we launch. So stage 1, we're really looking at our health workers and our frontline workers, and I believe also many of the journalists have been included in our phase 1, stage 1. Stage 2, we're then looking at our other adults and other people who could be at a higher risk. So a risk because of underlying conditions, or risk because of engaging with large populations. So for example, our teachers are engaging with classrooms of 30, 40, 50, 60, 70 children who could be carriers of it. So our teachers are probably likely in phase 2. Any other health workers who've been left behind, and then really the elderly. Stage 3, for us to reach 60%, again, as Dr. Mahomba has shown us, we basically need to immunize our whole adult population, everyone over the age of 16. So basically, phase 3 would basically look at everyone else who needs to be vaccinated for us to reach that 60%. And that's for us to achieve a concept called herd immunity. Herd immunity basically means that when a large enough number of the population has been vaccinated, even if 1 or 2 individuals get an infection, it will not multiply because the herd is immune. So the herd just means the group of people is immune. So even if a few people get infected, it will not multiply and escalate because the rest of the people are immunized, and it won't catch on. Or if it catches on, it's going to be very mild. So once someone gets vaccinated, what are going to be some of the signs and symptoms? So a person might get a very mild flu, just a runny nose, maybe some teary eyes, but that's about it. Might get a moderate temperature increase. Remember, with the vaccines, we're introducing a foreign body, so your body will respond a little bit in terms of, hey, what's this? There's something in the body that's new to us. Let's all see what's happening. These are the soldier cells which are talking. Let's go and understand it. So when that happens, there's a little bit of a temperature. But remember that what's been introduced is either dead or weakened, or it's just a protein, or it's just an RNA. The body will mount a response, and that causes your temperature to rise a little bit. But that very quickly comes down the next day or 2. And then there may be mild muscular pain, especially where you are injected. Obviously, a needle has gone into there, and then the vaccine itself comes in a fluid media. And so sometimes, that's introduced into our muscles, may cause a little bit of pain and discomfort. But again, very quickly, that will go down. So 95% of people will not have any major reactions. And basically, they'll just have these mild signs and symptoms. And many people might not even have anything, will not experience anything. Just from colleagues, when we've been monitoring the vaccinations, and basically the feedback is most people are not having any major events. Now, Dr. Mahom also talked about monitoring for major adverse events. So that's also very important, and we are doing that as a country. As we are vaccinated, there is a possibility that one individual may react severely and so we need to be able to document that, understand why that person reacted severely, so that at least if there's specific things, they can be investigated a little bit more. And if it's a type of condition or disease, we prevent or we adjust how we administer vaccines to that population with that kind of issue or disease. So that's why we have that adverse event monitoring team that's really looking at everyone who's been vaccinated. But I'm happy to say that we have not had very many major adverse events, and we continue to track all people who've been vaccinated in Zimbabwe. So with that, that's the end of my slide. I'll hand back over to the moderators. Thank you.
Well, thank you, Farai, for that very comprehensive presentation, looking at the nitty-gritties about the vaccine and how it works in our bodies. I note that there are quite a number of questions that are coming through. Continue to write questions on the chat box, and we will be able to have them dealt with when the presentations have been done. Next in line is going to be Dr. B.
I've admitted Kwangwari.
Of immunity, like we've been from the presentations that were before us. For us to achieve herd immunity, we want to have a certain number of the population being vaccinated. And if a significant chunk of the population chooses not to get vaccinated, it means we are exposing ourselves, and it means the consequences are far-reaching. It ceases to be a personal thing that I don't want to be vaccinated because we are dealing with a contagious disease. So it ceases. I mean, we all know what we all know the implication of one person getting sick. It's not only you, you're exposing other people. Even the national resources, we are using national resources for you to get treated when you go to the hospital. So it ceases to be something, it ceases to be my life, my choice. When you are exposing, when you are going to use resources for everyone, which resource, I mean, the resources which could be channeled to other things because of poor choices which people are making. When it comes to lifestyle, the things that we can do to improve and boost our immunity. Okay, someone says, I still don't want to get vaccinated. What can I do to boost my immunity? It's okay. There are things that we can look at, like nutrition, exercise, stress management. I'll start by talking about the issues of maybe if I can just give a rundown of the things that can help us in terms of our immune system. We had a presentation on vaccination, which we just heard from Dr. Charasika, explaining the issues of memory immunity, creating memory immunity. When we are boosting our immune system with diet, with exercise, with stress management, we are not creating any memory immunity. What we are doing, maybe we are getting ready our immune system to fight, but not supplements. You may get selenium supplements, or if you can't get those, we have things like different types of seeds that are high in these, your pumpkin seeds, your sesame seeds, different types of nuts, cashew nuts, that can help to boost your zinc levels. We're also looking at boosting your B complex, your vitamin B complex. So which you'll get from your unrefined, unprocessed grains. Mainly our traditional small grains will give you your B complex, your quinoa seeds, your yes, most of these unprocessed small grains. But the challenge which we mainly face when we are talking about life is not every day that a person is at high levels. Or for example, when you are taking a soft drink, let me talk about taking a soft drink. You may take a soft drink, a 300 bottle and 30 milk can, you reducing your immune system by about 60% for 5 hours, which becomes a challenge because you do not know when this virus is going to attack you. So if in your diet and nutrition or lifestyle practices,
for illness has the right to access basic health care service for illness. That is not happening. And people start to wonder when the government or those in authority are saying if we are giving you a vaccine of which the people, the majority, a citizen doesn't have the information on the issues like the advantages of the given vaccine. Do we have enough information on the vaccine, the sign of a vaccine which is being used now? Do we have a choice of the vaccines? Those where can are we able to choose how many vaccines are using currently in Zimbabwe? And are we having a choice, or we are just being told that we use this one, this vaccine, we use this vaccine? The issue of vaccine, the issue of do we have a choice given vaccines, or do we have that's the problem, or that's what the ordinary citizens are saying or asking from the those in authority. If we can have the information, and is the government doing effort to train COVID-19 information agents? The presenter giving a quite number of good things, good analysis, good presentation, which we got from the first presenter. But to the ordinary people, the people on the ground, is that happening? Or the information really on the ground? The other thing we have seen, we have heard on the social media, I can say we can, as much as the government can want to do to ignore social network, but social network currently is a very big, or is a great agent of change, which we cannot ignore because of its popularity and the activity in which the activity it plays in our lives. We have had a thought on the issue of the disadvantages of the vaccine. What the government really doing? What is the government really doing to suppress those? I can say those sentiments which are being thrown on the social media. The second thing is, was this Sinopharm vaccine clinically tested in Zimbabwe? The public wants to know if that Sinopharm vaccine was clinically tested in Zimbabwe. Then the other issue we saw our number one servant is saying that there is going to come a time. There's going to come a time when who choose or who be getting the job to get a job or not to use a Zupco, a bus. Is that the right way of persuading or giving information or teaching an ordinary person to the right way to prevent or even to the job? Those are some of the questions which an ordinary person wants to be addressed on this forum. The third thing I am going to talk about, I think we addressed it. Any efforts is the government doing any effort to train COVID-19 information agents so that they can give enough information on properties available, properties on the vaccines available. We heard the doctor saying that this vaccine, this virus has been for a long time, but it keeps on changing and keeps on changing. Then an ordinary person will say, why should I take a Sinopharm vaccine if it is not going to prevent me from the South African or the UK variant? I think those questions will are to be or should be addressed if we are to get head on immune. The third thing, the fourth thing I think should be also addressed is we are seeing people, ordinary people, have ignored all these measures, the announcements or the relaxing of the lockdown. What is the government doing? I will not be seen again going or having serious in the coming future. That is my presentation or some of the questions. Thank you.
Quite comprehensive. Some of the concerns, the burning concerns, really are fire. The officials look into. I should declare here and now that I'm part of the Rapid Communication and Community Engagement Committee, and the issues that you are raising have a lot to do with communication. I've also forwarded them to the team, especially when it comes to expectations on the vaccines, in that they are not adequately communicated to the public at large. And that, issues that have been mentioned by Dr. and also Dr. Chara, I think that needs to be shared greater. Thank you very much for that. And we are hoping that in the next coming session, the participants, the facilitators are going to address those. We've got 2-3 very interesting questions for the panelists to look at. Dr. Mahova, I'm sure you're still with us.
Yes, I want to start with the community presentation because the reason why we're all here is about our community individual. It's not about government structure. So on. At first, to appreciate and thank the presenter for really complimenting me on my presentation. I was sort of smiling when he was telling me, what did he say? This fruit is called what? And it's looking very pretty outside, but maybe it's rotted inside. That's an interesting way of putting it, but I still want to thank him for acknowledging the hard work that we're all doing. But if I start with the question, he says, what is government doing? This is one question I continuously get, and I'm continuously concerned because while government puts in place standard operating procedures, guidelines, the so-called presentation I gave you is the work of the government to put in place structures, you name it, things then work. The implementation on the ground is you and I, the employee of the Ministry of Health. It's an individual. Yourself in the community need to do something. We have put in the policy, the structures, the strategies, you name it, to guide you implement. So when we say government, what is government doing? This is what government has done. The next issue we would like to see, and remember I talked about complacency coming from you, the community. We are saying let's not be complacent. We are saying, can communities take ownership and drive it? Don't just sit to wait for government to drive it. We want you to drive it. So that ownership is critical, and I'm basically throwing it back to you to say what you say is what government is doing. What is now left is for you to take it on and take ownership. Efforts from government to give information, I think Mr. Moderator spoke to that. Will there be a time come to prevent people from riding Zupco and so on? I think once again, when I talked, I said we have challenges here and there. We never run away from our challenges. We never ever run away from our challenges. Indeed, trying to push people to get to volunteer, a difficult task indeed. Quite clearly, when it comes to say if you don't have if you're not vaccinated, can you ride Zupco or not? I think those are discussions that are still going on, and it is this input that actually helps us shape our strategies and approaches to say, we don't think this is good for the community, and we discuss it in our meetings and we recommend the right approaches that actually help you. We are helping you. It's not about putting SOPs just for the fun of it. Was Sinopharm clinically tested in Zimbabwe? I think perhaps when Dr. Charasika was presenting, he talked of clinical trials. These are the things that happen when you are developing the vaccine. These clinical trials are not so. If you get a paracetamol tablet, for example, one could say, so was paracetamol, did we do clinical trials for paracetamol? No, we did not. The clinical trials were done by the manufacturer of the drug, and then we look at the science of it. There are scientists who say, is it solid, is it what have you? That's what our Medicines Control Authority does. If we were to do a clinical trial for every single drug, your amoxicillin, antibiotic, anti-malaria, your what have you, we will basically be doing clinical trials and not addressing you. But we look at the science from the clinical trials done by the manufacturer of the drug. Sinopharm disadvantages. What is government doing to counter misinformation? I think you're absolutely. What we're doing here today is part of that. We sincerely hope those who are in communication then help us spread the information. Our business, when I'm sitting where I'm sitting, is to really make sure that the standard operating procedures, guidelines, approaches, you name it, it's in place. How are we guiding people? How are we coordinating? Then we have different units that pick on their own area. Remember, the whole of government that I talked about. Social media, you can't ignore it. You are absolutely right. And we have no intention of ignoring social media. What we are concerned about is when social media spreads misinformation. When social media tells people, don't take this because it hasn't been tested, when in fact they don't have the information. There was one that was circulating to say WHO has approached Zimbabwe saying Zimbabwe is using Sinopharm, which hasn't been tested. I took it upon myself as part of my job to phone WHO to say, is this your statement? Was it that you want to do? They disowned that immediately. That's circulating on social media, misinformation. And this is what we are saying. We have no intention of ignoring social media, but we are saying, can social media also be responsible? Make sure they are passing the right information and not misinformation. That's very clear. Is government spreading COVID-19 information? Ordinary people, I'm not sure if I understand that question. Do we have a choice? Absolutely. You do have sorry, so these are actually some of the questions that were coming from the chat. Do we have a choice? You do have a choice. But remember, if you choose to take Pfizer, which has not been cleared by Medicines Control Authority, how are you going to take it if it's out in UK only? It hasn't gone through the local science that we're talking about. Remember, government, it's a responsibility to safeguard the health of the nation in general, not just one particular individual. But you'll be happy to know that the Medicines Control Authority does actually sanction and give authority to certain individual drugs that might not have been approved for the general use and so on. But the process is the same. The science has got to be looked at. Has this drug gone through the clinical trials that supposed to have, it has supposed to have gone, which was manufactured, all that. They do that. I remember at one time people were talking ivermectin. How dare government not allowing people to use ivermectin? And eventually they say, oh yes, it has been authorized. No, it has not been authorized as such. People were using dog ivermectin. Ivermectin for dogs. That's not what government is there to approve such things. We would approve medicines for human beings that will have gone through clinical trials for use in human beings. And so when people want to use ivermectin, for example, the humankind one, it must be imported, the science must be there, and this is what Medicines Control Authority was talking about, authorizing to say, let's see the human type, where the data, where the clinical trials, where's the documentation, and then doctors, the real experts, not some who then pretend to be experts, know very clearly they can use any drug as long as it comes through the right ways, it has been checked by Medicines Control Authority, given approval. Government giving vaccine, yet majority have no information on other things. I think really government, just like we're seeing vaccinations a bit slow with the healthcare workers, we're making decisions to say, so should we just done until every single healthcare worker has been vaccinated? Shouldn't we just be moving and giving those who volunteer and so on? So it's not always about, if we can't treat your high blood pressure, therefore let's stop until we get that perfect before we introduce something to treat COVID-19. That would be very unfortunate. We keep moving with everything else while we are and acknowledge that we still have challenges, high blood pressure, diabetes, you name it. In fact, our experts advisory committee did a survey in December when we were concerned about that very question that the presenter gave us, that other essential health services were perhaps being compromised. We did that. We've since shared with the Ministry of Health. We're actually helping them. We strengthen how those other services continue to be provided, whether it's your high blood pressure, diabetes, and so work on that, but we're not going to start today. We're not going to say, we are still struggling with managing high blood pressure, so let's therefore hold this one for now while we try and make sure the high blood pressure is managed. Not at all. That is not public health. Public health includes attacking everything that comes our way, strengthening what is weak, acknowledging our challenges, and putting in place strategies, working with you, of course, the community. Once again, it's because we're doing this for you, not just for the sake of it. The next question was the health on is the right of everybody. I think that's what I was actually trying to address now, that it is your health, it is your right. Government puts in place the enabling environment. All make it up and make sure we're doing our part. Nice looking presentation. I think I already thank you for appreciating my presentation, but you're absolutely right. In that fruit that is looking pretty, there's still a few rotten apples. Some of the apples are our communities being complacent, so you name it. But of course, we never run away from the fact that government still has a lot to do. But let's always pay to what we can do and do it, and not to maybe just get too lost with the challenges. They are there to be addressed, absolutely. What does it take to improve our capacity in preparing for future pandemics? This is exactly what we're doing. This a question from the child. This is exactly out of vaccine. 12 at the very end, evaluation of the whole process. I did say at the end we want to know so that we're ready for the next epidemic.
Wow, thank you very much, Dr. Mahomba. That was very comprehensive. I was looking at my list of questions and you were ticking them. You were ticking all of them. You've done such a splendid job for us. And I'm quite sure that those who are participating here really did benefit from your presence in this webinar. And I'm quite sure that in the near future, when we are looking back at the process itself and how far it has gone, we are going to call on you once again to come and brief us on what is actually taking place. We would also like to extend our hearty thanks to you and the other panelists, Dr. Mbiriri, Dr. Charastika, and Marco, for also, for making this presentation, this webinar, such a very informative one coming through. And I'm quite sure that we can channel them to you directly, and you can answer them for. In fact, this last one from Zora Chekanyanga. Maybe you could, work on that one. It says there's Sinopharm work against the South African variant. The virus is mutating. Will people need to be vaccinated? I think this is very critical and requires your answer.
Yeah. That's fine. I think that question is everybody's question, really. This is one of the reasons why, and in fact, there was one I actually forgot I didn't quite respond comprehensively, where the capacity for are we building the capacity? We are, in terms of also doing genotyping to make sure we are clear in terms of what genotype we have here. We have since round that we did, we got support from a UK university, and we managed to see what variant there was with the first wave and so on. We did the second wave, and we've since received the equipment for us to do the genotyping ourselves. Lab scientists are being trained, and we are very confident that moving forward we will be able to do that. That will also help us then appreciate whether the Sinopharm is actually doing justice to the new variants that might come up. But I might bring you back to the science that Dr. Charasika gave us, where he was talking of the type of viruses and so on. A lot respond that attacks any variant that might have come are better than those vaccines that only target specific spikes, because it is those spikes that are usually instrumental in the mutation and coming up with new variants. So the idea of using a whole virus, killed virus, to mount a response is actually viewed to be more superior, and hence better able possibly to attack any additional variants than a vaccine that simply targets specific spikes, and it is those spikes that mutate, and when you have new ones, able to. But that's also work in progress, because remember, this is all new. But the good thing is, even if when you are vaccinated, we're saying we're trying to protect you from this, not getting it, but if you do get it, it will be mild. And of course, it means also you might not get the very severe issue of are you actually going on to die. So really, really, it's important that you get vaccinated. Don't worry too much about this variant, if it's not going to do any good to me. Really, you are better off the killed virus than a live, deadly virus attacking you. Thank you.
Thank you very much. We've run out of time. And fantastic. I'm sure the participants really enjoyed this. And I'm left to thank the participants for being there for the whole 2 hours and for a splendid webinar. And I'm quite sure that we will organize another one along similar lines. We thank the Media Center for having organized this. From me, Lennox Ntlanga, it's a great day to every one of you. We meet again. Bye.
Thank you. It's been a pleasure.
Thank you to everyone for the participation.
Thank you.